Thank you very much, Dr. Abdullah, for the introduction and for the invitation. When they sent me the invitation, they said cardio-oncology, a challenge. So I thought that as an interventional cardiology, bring a challenge what? So doing intervention in a patient with a cancer and giving him the probability of giving anticoagulation and the antiplatelet and this, but I thought this is not the right way, since this is a conference for general cardiologists and internists. So I changed the topic to challenges to the clinician, and I worked on that only yesterday evening and this morning. Okay, so I thought that I'll try to bring what's practical point between cardio-oncology drugs and our cardiology drugs. So there is a significant interaction, and the interaction could be from the pharmacodynamic point of view, whether synergistic, additive, or antagonist, or through the pharmacokinetic, whether that's affect the absorption, distribution, metabolism, or elimination of the drug. And this is one of the pictures. So if you concentrate there, is that a laser pointer? This is the one? Yeah. So that's may include the affecting the cardiomyopathy, the high blood pressure, the thrombosis, and we'll go through that quickly. So the hypertension is a common thing with the anti-cancer drug, especially the anti-VEGF inhibitor, and the incidence is around 40%. And that's related to suppression of production of nitric oxide, and the blood pressure, if we control the blood pressure, we may improve the prognosis of the patient. And the other medication is abiraterone, which is an androgen antagonist and used in the treatment of prostatic cancer. And the incidence here is also high, may reach 36%. And we know we give steroids or prednisolone with this medication to prevent the incidence of adrenal insufficiency. So, whether we are giving prednisone or not, that will not affect the incidence of hypertension due to this medication. We know also non-steroidal anti-inflammatory drugs used too much, and we need to pay attention to the hypertension. So I'll try to summarize that. For the tyrosine kinase inhibitor or the anti-VEGF, we need to monitor blood pressure, and the treatment of choice is ACE inhibitor or ARBs. And the second line is dihydropyridine calcium channel blocker. But for brutinib or Bruton tyrosine kinase inhibitor, we need to monitor blood pressure. And with that, because of the incidence of arrhythmia and QT prolongation, so it's better to give potassium-sparing diuretics that prevent the incidence of QT prolongation due to hypokalemia. Now, with abiraterone and steroids, just monitor the blood pressure and give steroids. And once there is blood pressure high, give the anti-blood pressure medication. The NSAID just consider that it may affect the blood pressure, and if we can convert to other medication, especially Tylenol, that will do the work. Now, for cardiomyopathy, everybody knows of anthracycline and the incidence that's happened due to effect on isomerase 2 beta with inhibition of this enzyme that may damage the mitochondria and the generation of free oxygen radical and intercalation of the DNA. But just remember, the more risk factor the patient has, the more incidence. So if he has hypertension, if he has the diabetes, previous history of heart failure, previous history of myocardial infarction, or a previous radiation therapy. Now the combination chemotherapy, especially the HER2 receptor antagonist like trastuzumab, increase the incidence of toxicity by 7-fold. So if we try to give them sequentially, we'll prevent the cardiomyopathy and try to avoid stopping HER2 blockage, because especially for breast cancer, if we stop that, we get 25% increase in mortality. So we will not hold this medication unless there is at least a moderate to severe symptomatic heart failure. However, if it's mild to moderate heart failure, and especially if it's asymptomatic, we may continue on this medication. The myocarditis is increasing incidence, especially with the immune checkpoint inhibitor. This immune checkpoint inhibitor are very active drug in treatment of cancer, especially melanoma and renal cancer. But if we give combination of two immune checkpoint inhibitor, or we give combination with tyrosine kinase inhibitor, that will increase the incidence of myocarditis, and the fatality rate is high. So we'll try to diagnose that too early, depending just on clinical suspicion, some ECG changes, and elevation of troponin. Once we get the suspicion, we try to start very high dose of steroids to prevent this myocarditis, because otherwise the fatality rate may exceed 50%. And we may continue to check MRI and further investigation, but just clinical suspicion by ECG and symptoms and elevated troponin, start high dose steroids. Thrombosis, we know every cancer patient has at least 4 times increase of thrombosis, and there are some risk score, but just I'll concentrate on some important point. The cancer treatment that increase thrombosis are tamoxifen, cisplatin, and VEGF inhibitor. Also, antiproteasomes that's used for treatment of multiple myeloma also increase the risk. Bonatinib is a drug that causes both venous and arterial thrombosis, and because it affects both the VEGF pathway and affect the platelet-derived growth factor. So it was taken from the market, but because of its efficacy, it's back, but with the recommendation to give both aspirin and low molecular weight heparin. Instead of low molecular weight heparin, we can use the DOACs unless the patient has GI malignancy, because if we use DOAC in combination with GI malignancy, there is increased bleeding. The antiplatelet therapy will leave it if the patient needs intervention. Now, also the patient with cancer also has increased risk of bleeding, especially if it's GI cancer, and the patient may require anticoagulation. So just remember 2 medications, and I'll concentrate on ibrutinib. It's a good drug, but it has side effects that increase the incidence of atrial fibrillation and also increase the incidence of bleeding. So the patient develops atrial fibrillation, we need to give anticoagulation, and he'll develop increased risk of bleeding. So with that, we need to monitor the patient closely with CBC and INR. And remember this complication: if the patient is taking any warfarin, the use of 5-fluorouracil or capecitabine increase the efficacy of warfarin. So for those patients, try to stop warfarin and get a substitution for that. The arrhythmia, just remember the QT prolongation is not happening just from the anti-cancer drug, because the patient develops bradycardia, he's developing nausea, vomiting, poor oral intake, and he's taking other medication, antibiotics, antiemetic, antidepressant. Just remember this name, ribociclib, that's increased the QT prolongation. And everybody knows this score for QT prolongation. So if we develop high score, just put the patient in the ICU and monitor. This is the box warning for arsenic trioxide and ribociclib. Just cause more QT prolongation. So for the pharmacokinetic, just I mentioned 2 things. Remember, clopidogrel is metabolized by C229. And if we give any suppressant, that the medication will not work. So keep that in mind, and you may need to switch to another antiplatelet. Now for permeated glycoprotein, we hardly use digoxin those days, but if you give anthracycline with digoxin, the absorption of digoxin is significantly suppressed. So if the patient need digoxin for rate control of atrial fibrillation, this will not work. Remember, for the supportive care, just I need 20 seconds. For the supportive care medication, we know we use antibiotic, clarithromycin, affect the cytochrome P450. So use azithromycin instead, because it will not affect that. For the antifungal, fluconazole is the safest one because it doesn't affect that. For the medication that affect elimination of the drug, remember, all those medications may affect the elimination of Tylenol, so we need to reduce the Tylenol. And the other medication is the patient if suffering of pain, remember, those medications may affect the concentration of morphine and hydrocodone. Now the last, every patient with cancer, we are giving him those medication as an antidepressant. And just remember, those antidepressants may affect this enzyme and make it inactive, and especially in breast cancer. Tamoxifen is the most common long-term medication, and this medication, if we are combining with this, we are suppressing the effect of tamoxifen and causing the patient to develop more cancer. So we need to pick the safest antidepressant, and the safest one is the trazodone and metrazepine. And that's the best way for that. So I think I tried to cover most of the important thing. That's about it. Although we are talking about cardio-oncology, but remember there is a common disease, not that common, but important disease, pulmonary hypertension, which is like a cancer and into proliferation. Remember, I'm not Hani Sabur, but we know all the medication for that. Everybody's talking about giving dilation. For that, you give arachidonic acid like prostacyclin, and you give the nitric oxide pathway, and you give the endothelin antagonist. But just this year, this is important, and this is against Dr. Shihab. He did not put in the schedule to cover the 6th World Symposium on Pulmonary Hypertension, which took place back in July. And with this medication, the activin inhibitor. So this activin induces proliferation of smooth muscle. And once we give this medication and this medication, sotatercept, it improved significantly the prognosis and the clinical findings of this patient. So that, I know I'm the last speaker, but we have, as Arab people, we live Kulthum to the end, and that's it.
Thank you very much.